Welcome to another episode from the Veterinary Research Channel. Today, we delve into a fascinating and important case report published in the Journal of Veterinary Internal Medicine in 2024. This article, authored by Julia Vanderslice and Maureen Carroll from the Angel Animal Medical Center, details a critical situation involving a dog that experienced severe electrolyte imbalances after receiving oral sodium phosphate for bowel preparation prior to a colonoscopy. As many pet owners and veterinary professionals know, preparing a patient for a colonoscopy often involves a thorough bowel cleanse to ensure clear visualization of the colon. This preparation typically includes dietary restrictions, enemas, and the administration of oral cleansing agents. In veterinary medicine, protocols for bowel preparation are often adapted from human medicine, where polyethylene glycol solutions and sodium phosphate are commonly used. While polyethylene glycol is gaining popularity in veterinary practice, sodium phosphate is another agent that can be used for this purpose in dogs. However, the use of sodium phosphate, particularly in the form of enemas administered in large volumes, has been previously linked to severe electrolyte abnormalities that can even be fatal in dogs and cats. This case report highlights that even oral administration of sodium phosphate can lead to significant and potentially dangerous electrolyte disturbances in our canine companions. The case in question involved a 15-year-old male neutered mixed-breed dog weighing 28 kilograms. This senior dog was presented to a referral center after developing severe tremors and an altered mental state. Upon examination, the veterinary team discovered that the dog was suffering from both hypocalcemia, meaning a dangerously low level of calcium in the blood, and hypernatremia, indicating a critically high level of sodium in the blood. These electrolyte derangements occurred after the dog received oral sodium phosphate as a bowel cleansing agent in preparation for a colonoscopy scheduled for the following day. The dog had a history of chronic large bowel diarrhea that had not responded to standard medical treatments, and ultrasound examination had revealed focal thickening of the colon. Additionally, the dog had a history of stage 2 chronic kidney disease according to the International Renal Interest Society guidelines and previous vestibular episodes suspected to be related to idiopathic vestibular disease. The dog's current medications were a probiotic and meclizine. Earlier on the day of presentation, the dog had been admitted for the bowel preparation. At that time, the dog was described as bright and alert with no neurological abnormalities. Initial blood work revealed mild azotemia, indicated by an elevated blood urea nitrogen of 49 mg per deciliter, and a creatinine level of 2.0 mg per deciliter. There was also mild hyperphosphatemia with a phosphorus level of 7.0 mg per deciliter. However, the initial sodium level was normal at 151 millimoles per liter, and the total calcium was also within the normal range at 10.9 mg per deciliter. As part of the bowel preparation protocol, the dog received intravenous lactated Ringer solution at a rate of 90 ml per kilogram per day, meropitant citrate, and oral sodium phosphate tablets at a dose of 15 grams, or approximately 535 mg per kilogram, every 4 hours for a total of 3 doses. The dog also received 500 ml warm water enemas every 4 hours. Food was withheld, but the dog had free access to water. Approximately 3 hours after the final dose of sodium phosphate, the dog became tachypneic, meaning it was breathing rapidly, and tachycardic, indicating an elevated heart rate. The dog was also laterally recumbent, and had a systolic blood pressure of 120 mm of mercury. Following a 10 ml per kilogram intravenous bolus of lactated Ringer solution and methadone administration due to concerns about abdominal discomfort, the tachycardia improved, but the blood pressure increased significantly to 180 mm of mercury. Subsequent blood work revealed marked hypernatremia with a sodium level of 168.3 millimoles per liter and ionized hypocalcemia with a level of 0.75 millimoles per liter. At this point, the dog received a 0.5 milliliter per kilogram dose of 10% calcium gluconate intravenously and was transferred for more intensive care. Upon arrival at the referral center, the dog was laterally recumbent and minimally responsive, exhibiting severe tremors that had persisted during the 45-minute transfer. The dog's core body temperature was elevated at 106.1 degrees Fahrenheit, and it continued to have tachycardia with a heart rate of 170 beats per minute and hypertension with a blood pressure of 180 mm of mercury. Harsh lung sounds were also noted. Repeat blood work confirmed ionized hypocalcemia at 0.65 millimoles per liter and hypernatremia at 168.6 millimoles per liter. An electrocardiogram confirmed sinus tachycardia. The immediate treatment involved active cooling measures, another 10 ml per kilogram bolus of lactated Ringer's solution, and a 1 ml per kilogram bolus of 10% calcium gluconate, followed by a continuous infusion of calcium gluconate at a rate of 0.5 ml per kilogram per hour. Following these interventions, the dog's mental status improved, the tremors resolved, and the dog was able to sit up on its own. However, chest radiographs revealed findings consistent with aspiration pneumonia and atelectasis. The treatment plan was adjusted to include a 0.45% sodium chloride solution at a rate of 120 ml per kilogram per day and tepid water enemas. The calcium gluconate infusion was continued, and empiric antibiotics were started to address the presumed aspiration pneumonia. Active cooling continued until the dog's temperature was below 103 degrees Fahrenheit. The hyperthermia was attributed to the severe tremors. No cardiac arrhythmias were observed. Over the next approximately 12 hours, the hypernatremia and hypocalcemia progressively improved and eventually normalized, at which point the calcium gluconate infusion was discontinued. The serum sodium concentration increased slightly during the day but resolved without further intervention as the dog began to eat and drink voluntarily. The dog remained neurologically normal for the remainder of its hospitalization and was discharged on the third day. 1 week after discharge, the hypernatremia and hypocalcemia had resolved, although there was a mild progression in the azotemia. Electrolyte levels remained normal for 2 months until the dog was sadly euthanized due to the progression of its gastrointestinal disease. The authors of the case report suggest that the dog's altered mental state and tremors were likely a direct result of the acute hypocalcemia, given the rapid improvement observed once the serum calcium levels returned to normal. They explain that hypocalcemia secondary to sodium phosphate administration is believed to occur due to the rapid absorption of phosphate, leading to severe hyperphosphatemia. This increase in phosphate then causes a decrease in ionized calcium through the law of mass action, as phosphorus binds with both ionized and protein-bound calcium, forming biologically inactive calcium complexes. This effect can be amplified in patients with reduced glomerular filtration rate, which impairs the excretion of phosphorus. While phosphorus and magnesium levels were not measured in this particular case, the underlying chronic kidney disease in this dog likely played a role. While hypernatremia could not be entirely ruled out as a contributing factor to the dog's acute decline, the authors believe it was less likely the primary cause, given the neurological improvements seen as calcium levels began to normalize while sodium levels remained relatively high. The authors emphasized the limited information available regarding the oral use of sodium phosphate in veterinary species. Their literature search revealed only one study specifically evaluating its safety profile in healthy research dogs, which reported no significant changes in serum electrolyte concentrations and only mild adverse signs such as vomiting. Other studies that used oral sodium phosphate as a bowel cleanser in preparation for imaging or surgical procedures did not report any adverse events related to the bowel cleanse, although this was not the primary focus of those studies. In contrast, complications associated with sodium phosphate administration are better documented in human medicine. A 2022 systematic review of 13 studies in humans found that a significant percentage of patients, ranging from 35 to 360 out of every 1,000, develop serum electrolyte disturbances after bowel cleanses with sodium phosphate. These abnormalities commonly included hypokalemia, hypernatremia, hyperphosphatemia, hypocalcemia, and hypomagnesemia. The clinical signs attributed to these imbalances range from mild to moderate, such as muscle weakness, constipation, nausea, and vomiting, to severe manifestations like paralysis, seizures, cardiac arrhythmias, coma, and even death in patients undergoing bowel cleansing. Elderly individuals appear to be at a higher risk for these electrolyte derangements, potentially due to factors like a more sedentary lifestyle, altered gut motility, constipation, systemic illnesses, and particularly an age-related decline in glomerular filtration rate. In human medicine, sodium phosphate is contraindicated in patients with congestive heart failure, kidney failure, and inflammatory bowel disease, and caution is advised in patients with kidney insufficiency and heart disease due to the increased risk of electrolyte abnormalities. It is important to note that these conditions are also commonly seen as concurrent illnesses in veterinary patients undergoing colonoscopy. Interestingly, there is limited research directly comparing the adverse effects of oral versus rectal administration of sodium phosphate in humans. Two studies that did compare the routes of administration found similar efficacy in bowel cleansing but did not specifically assess electrolyte disturbances. The authors highlight that the safe and effective dose of sodium phosphate in veterinary species has not been clearly established. The three veterinary studies that used oral sodium phosphate for bowel cleansing reported total doses ranging from 222 to 1,140 mg per kilogram. However, the origin of these dosing regimens was not cited by the authors of those studies. In comparison, published dosing guidelines for humans vary between a total dose of 125 and 600 mg per kilogram. The dog in this reported case received a total dose of 1,605 mg per kilogram, significantly higher than other published doses in both human and veterinary literature. The authors suspect that this elevated dose, combined with the dog's pre-existing kidney disease and colonic disease, likely predisposed it to developing the severe electrolyte complications. In conclusion, this case report serves as a critical reminder that oral sodium phosphate should be used with caution in dogs, particularly those with underlying chronic kidney disease or other systemic illnesses. The authors strongly recommend that serum electrolytes should be carefully monitored both before and after the administration of sodium phosphate. This vigilance can help in the early detection and management of potentially life-threatening electrolyte derangements in our veterinary patients undergoing bowel preparation for diagnostic procedures. Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.